The topic is now hematinics from your chapter of cytopenia and other drug-forming drugs. I am Dr. Mubasherah, Pharmacology Department, and now we are going to start the drugs which are responsible for forming various blood cells. Now, what are hematinics? Hematinics are all the agents used in cytopenias and anemias, and those are iron, vitamin B9, vitamin B12, and erythropoietin. Before starting the drugs responsible for the treatment of anemia, we should know what is anemia. So by anemia you have to understand two things: either it is a deficiency of red blood cell count, or either it's a deficiency of hemoglobin less than normal. Both of these conditions will lead to decreased oxygen carrying capacity of the RBCs, ultimately decreased oxygen supply to their various body organs, and hypoxia and anoxia can occur. Where does all the blood cells form? We all know all the cells are formed primarily in the bone marrow, but bone marrow needs certain essential nutrients, vitamins to produce RBCs, WBCs, platelets, all these progenitor cells. And what are these main vitamins? Iron, vitamin B12, folic acid, it's also known as vitamin B9, and other hematopoietic growth factors like erythropoietin. These are the proteins that regulate the proliferation and differentiation of all the hematopoietic cells. So, if in any condition the iron is lacking, vitamin B12 or folic acid or hematopoietic growth factor is lacking, it will lead to deficiency of functional blood cells. What does it mean? There may be blood cells, but their functioning capacity is decreased. So depending upon the cause, we can classify anemia first. The deficiency of iron leads to iron deficiency anemia. The deficiency of vitamin B12 and folic acid leads to megaloblastic anemia. And there are certain drugs which causes the bone marrow to produce less or abnormal RBCs, especially certain cytotoxic cancer drugs. Another kind of anemia is something related with the absorption, not with the deficiency. Less absorption of or abnormal absorption of vitamin B12 in small intestine. So the anemia which is caused by faulty absorption of vitamin B12 in the small intestine is pernicious anemia. The anemia which is due to the deficiency or excessive loss of iron is iron deficiency anemia, and the anemia which is due to less intake of vitamin B12 and folic acid is megaloblastic anemia. Megaloblast means large cells. They are unable to mature into functional blood cells. So we will classify broadly the causes: iron deficiency, B12 deficiency, folate deficiency, decreased red blood cell production owing to different reasons, blood loss again owing to different reasons, or if all of the things are normal but red blood cells are being destroyed at a very fast pace, then this will also cause anemia. But today in this topic we will read only the types of anemia which are caused by deficiency of iron, B12 and folate. So normally what happens, if you have something less endogenously, we will give the same thing exogenously. Means if you have iron deficiency, vitamin B12 deficiency or folate deficiency, what you will do? You will do iron, you will give B12 and folate. When we said that anemia is also caused by decreased or faulty red blood cell production, then what happens? The body produces very few blood cells, one condition, and the other condition, blood cells may be in normal count but they do not function correctly. So what is the result? Abnormal red blood cell. This is due to the also lack of minerals and vitamins. So all these conditions by now you know are iron deficiency, vitamin deficiency, and the third condition we are talking about here now, sickle cell anemia. Sickle means crescent shape, okay? So the red blood cells formed in sickle cell anemia are crescent shape. What happens in iron deficiency anemia? There is no iron or there is deficiency of iron. Now why we are so worried about iron? Because bone marrow, when it's forming blood cells, when it's forming hemoglobin, it needs iron. Without adequate iron, the body cannot produce enough hemoglobin for the RBCs. The result is iron deficiency anemia. This type of anemia can be caused by either you are not taking proper iron diet, or you are taking proper and adequate but your metabolic demands are high. There are certain conditions like pregnancy, like breastfeeding, that depletes women's iron store more rapidly. The other again, menstruation, you have excessive blood loss and excessive loss of iron. The other condition is frequent blood donation. If you are a frequent blood donor, then you can also encounter iron deficiency anemia yourself. Last, digestive conditions. Certain Crohn's disease or surgical removal of part of the stomach or small intestine, they will lead to deficient absorption, or vitamins which are needed for the absorption, they will decrease because of the resection of that particular part. Or there is a condition Crohn's disease. What is Crohn's disease? It is an inflammatory disease. Vitamin deficiency anemia is caused mainly due to B12 and folate. All of these are again needed for. The types of anemia are megaloblastic anemia, pernicious anemia, dietary deficiency anemias. So what happens in megaloblastic? B12 or folate or both are deficient. Pernicious anemia is poor vitamin B12 absorption. It's not related with the deficiency. Dietary deficiency means you are eating less amount of these vitamins, as the only source of these vitamins is your diet, and if you are not taking vitamin rich diet, you will encounter deficiency. Other causes are increased metabolic demands, pregnancy, and certain medications like cytotoxic drugs, alcohol abuse, and other conditions are intestinal diseases like earlier I said Crohn's disease. Sickle cell anemia, first you will understand the red blood shape is crescent shape rather than normal oval shape. Now because of its shape, they break down rapidly. So oxygen does not get to the body's organs, causing anemia. Means the crescent shape RBCs are being forming, but they are not able to carry oxygen. So what's the use of them? So ultimately they break down rapidly. And plus another thing, because of their shape, they also get stuck in tiny blood vessels, causing pain. So sickle cell anemia is an inherited disorder and it is due to the genetic defect. Here you can see the normal red blood cell shape and the sickle cell red blood shape, and beneath you can see the vessel. The normal red blood cells can flow very easily and smoothly, but the sickle shaped cells, they are being stuck in the smaller capillaries. The other kind of anemia is resulting from the bone marrow or stem cell problems. These two types of anemias are aplastic anemia and thalassemia. Whenever you are using these terms like aplastic, anuria, anoxia, A means absent. So aplastic anemia is the absence or marked reduction in the number of stem cells. It can also be an inherited condition. It can cause without apparent cause, or it can even occur when the bone marrow is injured by various reasons, medications, radiation, chemotherapy, or infection. So what is aplastic anemia? Total absence or reduction in the number of stem cells. The other kind of condition is thalassemia. Nowadays, you may heard this word in news that there is a problem with thalassemia patients. So you must know what is thalassemia. Thalassemia occurs when the red cells cannot mature and grow properly. It is also an inherited condition, and it can range in severity from mild to life-threatening. And the only treatment option for thalassemia is either blood transfusion, blood exchanging means, or bone marrow transplantation. So that's why you are hearing these news thalassemia patients having problem, because now they have less places or less chances to do their blood transfusions nowadays. Here you can see the clear picture of aplastic anemia on one side and the other side thalassemia. Here under the aplastic anemia you can see all the progenitor cells, all the blood forming cells, platelet, RBCs, WBCs, they are not being formed. But in thalassemia you can see the malformed red blood cells, distorted type of shape. It's not sickle shape. You can see sickle shape is different. It is different malformed red blood cell, and the basic problem in thalassemia is in the formation of hemoglobin porphyrin ring. So depending upon the cause, we have classified thalassemia further into alpha thalassemia and beta. These are few terms which you can even observe in when you have a complete blood count test. So there are certain terms which you encounter like microcytic, macrocytic, normocytic. Now this term refers to the size of the RBC. Size of the RBC, microcytic is smaller than average, macrocytic is larger than average, and normocytic means normal. So there are certain codes. So whenever you see a complete blood count picture, only by the size of the RBC or only by the value of the MCV, you can have a clue of the condition like iron deficiency or chronic anemia or folate deficiency, vitamin B12. So from here you can start your diagnosis. Okay, it's microcytic, it can be iron deficiency. It's macrocytic, okay, it can be folate deficiency or vitamin B12. And here you can see what actually means normal and down beneath the figure. Normal, microcytic you can see small sized, macrocytic you can see bit bigger, and hypochromic you can observe that there is a slight difference in the color of the RBCs. So hypochromic means less color. How you can diagnose that person is suffering from iron deficiency even at your home, in your families? So these are very common symptoms: easy fatigability, tiredness. Sometimes when you climb the stairs there is shortness of breath. Sometimes you have no reason but you are feeling or encountering depression, and in girls you can observe the hair loss and you don't understand why is the problem of hair loss. So sometimes there is deficiency of iron, sometimes there is deficiency of zinc. The other thing is headache. Because why? Because if you have iron deficiency anemia means you have less oxygen capacity, and sometimes the cause of headache is you are getting less amount of oxygen to the brain. Coming to the main topic, what kind of drugs or what kind of supplements we are giving in all these type of anemias. Hematinics are classified as 3 categories: erythrocyte factors, platelet factors, granulocyte factors. So erythrocyte factors can be further classified into vitamins, 2 types: B12 and folate, iron, and erythropoiesis stimulating agents, ESAs. The platelet factor is opilvecin or interleukin 11. The granulocyte factors are filgrastim or sargramostim. GCSF. G stand for granulocyte, C stand for colony, S stand for stimulating. Now again the other side, GM. G stand for granulocyte, M stand for macrophage, and C, S, F are same. Now what are the hematinic agents? These are the drugs which are used to stimulate the formation of red blood cells, and they are used primarily in the treatment of anemias caused by the deficiency of these things. Now we will come to the first thing, iron. You have to understand how iron is metabolized after the intake. The iron preparations are in the form of ferrous sulfate, and whenever you take ferrous sulfate, it is not an iron salt. First, it has to break down within GIT, and then the elemental iron is released, which is absorbable. When you intake iron, it is not an iron salt. It has to be changed into ferric form. Now here comes the difference between ferrous and ferric. Remember that ferrous is Fe3+, ferric is Fe2+. Ferrous is when there is a loss of 3 electrons. Ferric is when there is loss of 2 electrons. So approximately 60% of iron is stored in the hemoglobin in RBCs. Only 9% is stored in myoglobin. 25% is held in the storage form in the reticulocytes of liver, spleen, and bones. So whenever you are encountering a condition of iron overload, the iron overload will also be in the liver, spleen, and bones. What happens to the stored iron? Iron is stored and is bound to the protein ferritin. Here you can see in the figure as well, down beneath is written ferritin, and in the bracket it's written it stores iron. While being transferred in the body, ferric iron, Fe2+ iron, is converted to ferrous by ceruloplasmin, being transported by protein transferrin. Now the difference is transferrin is the vehicle which transports iron, and ferritin is the storage form. Difference between transferrin and ferritin. Transferrin is a vehicle which takes iron to different places, and whenever iron is stored, it is stored in the form of ferritin. Now if you look at this figure, it shows the different amount of iron which is being used, or which is being absorbed, or which is being stored. So whenever we take iron, usually we take 10 to 20 milligram iron. It goes to the intestine, it gets absorbed, then it goes 75% to the erythropoiesis, to the RBCs, 10 to 20% is stored, and 5 to 15% is used for other processes. A very small amount is lost from the body only by the process of desquamation of epithelia. Now what is desquamation of epithelia? Means your skin cells, the upper surface of the skin cells, they get desquamated, means they shed, and with this small amount of shedding, the iron is being lost. Why iron is important for our body? As you all know by now, that it forms the nucleus of iron porphyrin ring, which together with the globin chain forms hemoglobin. So hemoglobin is very important for us. Why? Because it gives us oxygen, and hemoglobin needs iron for its proper functioning. So this is the role of iron. In the absence of adequate iron, small erythrocytes with insufficient hemoglobin are formed, giving rise to microcytic hypochromic anemia. Microcytic, small size, hypochromic, less red colored, and anemia means lack of hemoglobin or lack of. Now we will come to the pharmacokinetics of iron. As you all know, free inorganic iron is extremely toxic. The body has to convert it into ferric form, but we need free iron in the body as well in the stored form, so we can use it for our hemoglobin synthesis. So iron is required and it is regulated by absorption, transport, and storage by a specific system. This system has two proteins, ferrireductase and ferrioxidase. Now, who controls these two proteins? The body itself. The body's demand for hemoglobin synthesis and adequate iron stores. This tells the ferrireductase and ferrioxidase to be produced and to get functional. What do you understand by this paragraph? The iron is absorbed, transported, and stored. There are few things which help the iron to go through these processes. So there are specialized proteins, ferrireductase, FR, it will be denoted in the figure, ferrioxidase, FO. Now, there is another peptide called hepcidin. This is produced primarily by the liver cells, and this served as a key central regulator of all this absorption, transport, and storage system of the iron. Nearly all of the iron is used to go for hematopoiesis, and when the lifespan of the RBC is completed and after 120 days the RBC ruptures, then again this iron is reclaimed from the RBCs from the catalysis of the hemoglobin in the damaged or senescent erythrocytes, right? Means iron is going into RBC to form hemoglobin, right? After 120 days, when the lifespan of RBCs have done, it will damage or it will burst, it will release iron. So again, this iron is reclaimed from the catalysis of hemoglobin for further use. This is the same thing, all this in the. Now, whenever it reaches in the pink portion, means in the blood, iron is transported by transferrin. This transferrin iron complex binds to transferrin receptors in the erythroid precursors. Keep looking at the figure in your books while I am telling you all this. Keep looking in the figure. So, and hepatocytes in the hepatocytes, and this complex is internalized. After entering in the hepatocytes, this complex releases the iron, and the transferrin complex is recycled again to the plasma membrane and TF is released. The cell which I told you, the macrophage, that phagocyte is senescent RBC, reclaim the iron. Reclaim means they demand iron from the damaged RBCs to give us our iron back, okay, and either export it or store it as ferritin. The other cell we have seen is the hepatocyte, which use several mechanisms to take up iron and to store iron as ferritin. Here you can see, just concentrate on the part of the figure where you can see erythroid progenitors. This iron, it is being used by all these erythroid progenitors to mature further. And other thing you can see is a cell above the cell is written macrophage, and in the macrophage you can see a round oval, that is the senescent RBC which is being engulfed by the macrophage, and now this iron is being reclaimed from the RBC to use it further or to store it further. So whenever you will write pharmacokinetics of iron, Again, you can divide like this: absorption, distribution, metabolism, and excretion. Absorption, as you all by know, ferrous form and poorly absorbed in healthy individuals, but in patients suffering from iron deficiency anemia up to 60% dose is absorbed. Distribution, as you all know, it is distributed in the form of transferrin bound to the bone marrow for incorporation into hemoglobin. Metabolism, the iron liberated by destruction of hemoglobin is reused by the body. Excretion of iron is minimal. As I have said earlier, it is lost in very small amount by desquamation, by nails, by feces, by sweat, and by bile, but it's very small. The total body iron is divided into few things. Hemoglobin means percentage of the iron going to hemoglobin is 70%. Percentage and amount of ferritin and hemosiderin out of 3600 milligram. The total body iron is 3600 milligram. So out of this proportion, 1000 milligram is stored. 300 milligram goes into myoglobin, 100 milligram goes for cytochromes and other enzymes, and you can see 2200, major of it, 70% of hemoglobin uses the iron. This is all the summary of absorption, distribution, storage, utilization. It's a very interesting figure. Here you can see iron being absorbed, then iron being stored as ferritin, iron being utilized in myoglobin, iron being recircled from the senescent RBCs to reclaim iron again, and in the end you can see iron loss, and here you can see desquamation. The cells are being desquamated. So no physiological excretion mechanism other than this loss. To whom you will prescribe or iron? Only and only in iron deficiency anemia. No other indication for iron. Iron preparations are usually in the form of ferrous sulfate, ferrous fumarate, and gluconate. Now, where you will not give iron is very important, because it is our very common practice to prescribe iron without knowing any underlying physiology of that patient. So you have to always be very cautious of giving iron, because if you will not give iron, nobody will die, but if you give overloaded iron, somebody will experience life-threatening experiences. So what is the contraindication? The major contraindication: hemolytic anemia. Hemolytic anemia, due to any cause, it destroyed RBCs in very rapid speed. So whenever RBCs are being destroyed, the iron is being liberated, as we have understand by now. So if there is if destruction of RBC means there is excessive amount of iron being reclaimed from that RBC, right? So do not give iron to that person. The person has already loads of iron. Then there is a condition is hemochromatosis. This is the excessive load of iron in the body. Now there are certain conditions where the iron metabolism is not properly working. So there is already an iron overload in that person. Do not give iron. Certain gut conditions, peptic ulcer, regional enteritis, ulcerative colitis, and the people who are receiving repeated blood transfusions, they also have iron overload because of their repeated blood transfusions. There are certain drugs which you have to be very cautious while giving with the iron. The drug names are tetracyclines, penicillamines, methyl-dopa, levodopa, carbidopa, cipro, norfloxacin, and ofloxacin means quinolone group. So do not give iron with these drugs. Why? Because iron chelates in the gut with all these drugs. Means they iron combines with these drugs and they alter its absorption. The other kind of drugs is thyroxine, captopril, and biphosphonates. It forms complexes with these drugs and again alter their absorption. Now if you are encountering a condition that you have to give iron and you have to give any of these drugs, then what is the way of giving is the ingestion should be separated by 3 hours. Means you will give iron at 9 o'clock and then you will give any of these drugs at 12 o'clock. Okay. Now there are certain things which can increase absorption and certain things which can decrease iron absorption. Vitamin C increases its absorption and desferroxamine, T, calcium, zinc and bran decreases absorption. If you are prescribing iron, you can have certain adverse effects which you don't want are epigastric pain, heartburn, vomiting, staining of teeth. This is most common. Metallic taste, it's also again common, and constipation. If you are giving excess iron, then you can face two conditions: acute iron toxicity or chronic iron toxicity. What happens in acute poisoning? 10 to 20 milligram iron has been ingested, and usually it happens in children. Symptoms being vomiting, abdominal pain, lethargy, cyanosis, convulsions, shock, or serious failure in severe conditions. So how will you treat it? You will induce vomiting, you will give certain things, certain home remedies, egg yolk or milk, and a drug named DESFERRIOXAMINE. This is an antidote of iron toxicity in 100 ml normal saline. Another drug used is to use chelate iron. Chelate, what do you understand by chelate? Chelate means the thing combines with that the other particular thing and then it is not able to absorb in the body. Desferroxamine is a chelating agent. It binds with free iron in the blood and forms a water-soluble desferroxamine. Now you know by all, or you all know by now, that if you want to excrete something, you have to make it water-soluble. So what does desferroxamine do? It chelates, it binds with free iron, the excessive iron in the acute toxicity. It binds with it and it makes it more water-soluble, so it can be readily excreted. The other treatment is whole bowel irrigation should be performed to flush out the unabsorbed pill. In the old times, people used to give activated charcoal. It's a black powder form and usually it is given in any kind of poisoning, but in this case, in iron overload case, it does not bind iron and it is totally ineffective. So people don't go for charcoal in the case of iron toxicity. Now, chronic iron toxicity is called hemochromatosis because it results from the excess of iron stored or deposited in the heart, liver, pancreas and other organs, and ultimately all these organs suffer, fail and death occurs in very severe cases. So in these patients, what you will do now, this is treated by intermittent phlebotomy. What does it mean? It means 1 unit of blood is removed every week until all the excess iron is removed. Here we ended with the first supplement, that was iron. Now we will talk about folate deficiency and the anemia caused by folate deficiency. In this figure you can see folate, as it is adequate, then there is normal cell division and normal red blood cell production. But if the folate is deficient, then you can see only one big cell, and this is a megaloblast, and that's why the anemia caused is called galloblastic anemia, and it gives rise to macrocyte, a bigger size cell. So deficiency of folic acid is a low level of folic acid in your diet. This folic acid is also known as vitamin B9. Now, why we are worried about folic acid? What is the role of folic acid in our body? Very important role. It is involved in the DNA synthesis. So you see, whenever a lady is pregnant, we are prescribing multivitamins plus folic acid. Why? Because it is very important for DNA synthesis. So if the folic acid is deficient, The deficient kind of RBCs, large-sized cells, megaloblasts, are produced, which are unable to perform their actual function or which are unable to mature into proper RBCs. Not always it's because of the deficiency. There are certain very commonly used drugs which inhibit the derivatives of folic acid, dihydrofolate, reductase, which can ultimately cause folate deficiency. And what are these drugs? Methotrexate, trimethoprim, and pyrimethamine, and phenytoin. Like this is not always due to deficiency. It can sometimes due to these drugs as well. So from where you can get folate or folic acid? From your diet, liver, cereals, nuts, green vegetables. When you talk about pharmacokinetics, it is administered through oral or in severe cases in parenteral routes. It is absorbed from the proximal jejunum and it is widely distributed and somewhat is stored in the liver as well. So what is the function of folic acid in our body? It is converted to tetrahydrofolate by dihydrofolate reductase. This enzyme reduces dietary folic acid to tetrahydrofolate, and it also regenerates tetrahydrofolate from dihydrofolate. So, what is the function of folic acid in our body? It is necessary for the formation of DNA, purine synthesis, and in which form it is available? It is available in the form of folinic. Now there are two reactions in the body: the conversion of DUMP to form DTMP. While listening to this slide, you can open your book and you can look at the figure so you can understand better. In your chapter of cytopenias, you have a figure where all the cycle of folate is being shown. Here you concentrate what I am talking. Now in the figure, look for where it is written DUMP being converted to DTMP and all these things you will see. Now see what happens. This tetrahydrofolate cofactor is responsible for the production of DTMP from DUMP. DTMP, why it is necessary? It is necessary for purine and DNA synthesis. So whenever there is a problem with the folate, when there is no folate, there is no conversion, so there is deficiency of this thing which is necessary for DNA synthesis. So whenever DUMP is converted to DTMP, 1 mole of tetrahydrofolate is used. Means for the production of DTMP, many tetrahydrofolate are needed. So this continued DNA synthesis, you need continued amount of DTMP, and for that you need continued amount of or sufficient amount of tetrahydrofolate or folic acid. This combined catalytic activities of DTMP synthetase, dihydrofolate reductase, and serine are referred to as DTMP synthesis cycle. This is the figure. Now, from where you will start looking at? From beneath, where it is written formate. Have you find it? Okay. Now, what is this written? Formyl tetrahydrofolate. Then above, methynyl tetrahydrofolate. Then again, methylene tetrahydrofolate. Then above, methyl tetrahydrofolate. Now, in between this step, methylene tetrahydrofolate, you can see the two arrows which are showing the conversion of DUMP to DTMP from methylene tetrahydrofolate, right? And then there is another reaction above, you can see from methyl tetrahydrofolate. The other reaction is homocysteine is being converted to methionine, but in between you can see is written B12. Means even if you have folate, you still need vitamin B12 for the conversion of this process, the conversion of homocysteine into methionine. Okay, so here again from this figure I will explain to you what I told you earlier, the folate trap. What happens where you can see methyl tetrahydrofolate. If this process ceases, this conversion of homocysteine to methionine because of the lack of vitamin B12, methyl tetrahydrofolate is not being metabolized further, and it serves as a sink, as a reservoir, and it is useless, and it causes a folate deficiency even if you are taking the normal amount of folates, right? This is the exact figure in your book. This is the same figure. Here you can see clearly N5 and 10 methylene tetrahydrofolate. This is being used to form purines, and on the side you can see DUMP to DTMP. So this is the folate trap which I told you. If the homocysteine is not being converted into methionine, the tetrahydrofolate N5-methylene tetrahydrofolate accumulates, and it serves as a folate trap, or trapping of the folate pool occurs. In its deficiency, the DUMP is not being converted to DTMP, and the DTMP levels drops down, hence DNA synthesis is also slowed down due to non-availability of these deoxyribonucleotides. Pharmacokinetics of folic acid, coming with the absorption, transport, normally absorbed from duodenum and upper jejunum, and up to a little extent from lower jejunum. It exists in nature as folate in polyglutamate form, means conjugated form. This polyglutamate form is first cleaved to mono and di, which further undergo reduction by the tetrahydrofolate reductase into monoglutamate. Here you can see the conversion of folic acid. Folic acid you have from the intestinal lumen. On one side you can see intestinal lumen. The cell is an enterocyte, and from the cell it is being absorbed into the plasma. So in the enterocyte you can see the conversion of folic acid into dihydrofolate. Dihydrofolate is then converted into tetrahydrofolate, and this tetrahydrofolate is being used to be converted into 5-methyl tetrahydrofolate, which is then absorbed in the functions. Up till now you understand that folic acid took place in two reactions. One is the formation of DUMP into DTMP. The other is the formation of methionine from homocysteine. So whenever you have been asked what is the role or what is the function of folic acid in the body, it is responsible for purine and pyrimidine synthesis, and it is responsible for conversion of homocysteine to methionine. So whenever you will have deficiency, you will face complications in the form of megaloblastic anemia, low level of WBCs and platelets, and ultimately neural tube effects. There is no recognized toxicity with the folic acid. Up till now we ended the second element, the folic acid. Now we will come to vitamin B12 deficiency, and its deficiency is usually because of decreased intake, impaired absorption, certain drugs, and other conditions. Why we are worrying about vitamin B12? Because it is involved in protein synthesis, involved in DNA production, carbohydrate and lipid metabolism is also being carried out in the presence of vitamin B12, and the most important, as we have talked earlier, it is utilized in DUMP to DTMP conversion as well. Cyanocobalamin and hydrocobalamine are the terms which are being used for vitamin B12. So the drugs with the name of methicobal or cobalamine, they all are the formulations of vitamin. dietary requirement is only 2 to 3 microgram, and around 3 to 30 is already being obtained from our normal diet. This means that body requires a very small amount and you are taking abundant amount normally, so there are very less likely that you face vitamin B12 deficiency. Only the certain condition is of the malabsorption actually, which mimics to deficiency of vitamin B12. Otherwise, your diet contains sufficient amount of vitamin B12 and there are very less likely chances to cause its deficiency. If it is seen in this problem where you can see there is a lack of intrinsic factor which is responsible for the vitamin B12 absorption. So this kind of anemia which is caused by vitamin B12 deficiency is called pernicious anemia, where there is a problem with absorption, not with the intake. And if there is a process of gastrectomy, means a part of the stomach is resected where usually normally vitamin B12 absorption occurs. So this will also lead to vitamin B12 deficiency, as there is no area, no intrinsic factor for its absorption. So the conditions which are leading to its malabsorption are gastrectomy, small bowel resection, malabsorptive disorder, inflammatory disorder, and in strict vegetarians as well, as the source of vitamin B12 are usually meat. So in strict vegetarians, they usually do not take meat at all and they suffer deficiency. What you will do for its treatment: parenteral vitamin B12 in the form of cyanocobalamin, hydroxycobalamin. But if the patient cannot tolerate, you can go for oral or intranasal route. But again, oral is not recommended in the form of malabsorptive disorder. If you have problem with the absorption, what you will do by giving oral? Nothing, zero result. So you have to go through parenteral. With parenteral vitamin B12, improvement comes in about few days, nearly about 7 days, and the deficiency normalizes in a couple of months. Pharmacokinetics: it is stored in the liver. Storage pool is quite enough, 3000 to 5000 micrograms, and loss is very slow. So these stores are sufficient for 5 to 6 years. So animal source is meat, eggs, dairy products. Liver function, as you all know by now, it is responsible for DNA synthesis, fatty acid metabolism. Both of them together, vitamin B12 and folic acid, they participate in the metabolism of homocysteine, as I have shown you earlier. So if accumulation of homocysteine occurs due to deficiency of these vitamins, certain other problems can occur like atherosclerosis. It becomes a positive feedbacker of causing atherosclerosis. The deficiency, vitamin B12 deficiency, leads to again megaloblastic anemia, GI symptoms, and neurological abnormalities. When you are talking about vitamin B12 metabolism, you have to be somewhat particular, because there is some common thing, some intrinsic factor that is responsible. So here we go. Once you take vitamin B12, it is bound to a protein, R protein, in the stomach. Keep looking at the figure as well. In the stomach, it is bound with the protein R. Okay, now it has to be liberated from this protein. So what comes to liberate it? Pancreatic protease. Pancreatic protease release vitamin B12 from this R protein in the small intestine, where again this vitamin B12, it binds to the intrinsic factor IF. Being bound to intrinsic factor, which is produced by the gastric parietal cell, vitamin B12 is now transported from small intestine to terminal ileum. Now what happens in terminal ileum? Enterocytes absorb vitamin B12, break this complex of vitamin B12 and intrinsic factor, and releases vitamin B12 into the portal circulation, again bound to transcobalamin From there, it is then transported to different tissues throughout the body. So, what is particular about vitamin B12 absorption? You will have to memorize two things. One is in the stomach, or protein, then in the small intestine, intrinsic factor, then in the ileum, transcobalamin 2. In the form of transcobalamin 2, it is transported to different tissues throughout the body. So human keep recycling it via enteropathic circulation, and it is excreted in bile and again reabsorbed in terminal ileum. So usually there is enough storage of the vitamin B12. When you will talk about functions of the vitamin B12, these are same as we have seen in the previous figure. It is used for the conversion of homocysteine to methionine, and it is used for the conversion of methyl manonyl CoA to succinyl CoA. Now what is succinyl CoA? It is responsible for the lipid and carbohydrate synthesis. That's why we said earlier that vitamin B12 is also responsible in lipid and carbohydrate synthesis. Okay, so functions of folic acid are purine and pyrimidine synthesis, DTMP, DUMP, and homocysteine to methionine. And the functions of vitamin B12 is the conversion of again methyl tetrahydrofolate to tetrahydrofolate active form, and the conversion of methyl manonyl CoA to succinyl CoA, which is responsible for lipid and carbohydrate synthesis. Clear? Uses of vitamin B12 and folic acid. Of course, the condition of megaloblastic anemia, you are giving vitamin B12 and folic acid. In malabsorption syndrome, you will give parenteral, but in case of deficient intake, you can give oral forms. Here we ended with the third supplement, vitamin B12. So we ended iron, folic acid, and vitamin B12. Now comes the other additional hematopoietic growth factors, erythropoietin. Now before we starting erythropoietin, you know what is erythropoiesis. You all know what is erythropoiesis. It is the formation of a process of formation of RBCs. And how it happens? It happens because of a stimulation of a hormone, erythropoietin. Now where is erythropoietin? Erythropoietin comes from kidneys, and the function of erythropoietin is to stimulate erythropoiesis. So in the figure you can see a stem cell, then converted into committed cell, proerythroblast cell, and then these all maturation end to a proper RBC formation, and this formation of RBC is called, from the stem cell to the erythrocyte, it is called erythropoiesis, and erythropoiesis is carried out with the help of erythropoietin. This is the normal physiology. When start looking from the above, low blood oxygen stimulates two organs, liver and kidney, to produce erythropoietin. Okay, then erythropoietin is released into the bloodstream. It goes into the red bone marrow. It increases the stimulation of RBC production, and when there is adequate amount of RBCs formed, then this increased number of red blood cells performs as a negative feedback mechanism for erythropoietin, and the erythropoietin stops being produced. Means whenever you have low blood oxygen, you have erythropoietin. Low blood oxygen was because of low blood cells. Erythropoietin what causes? It causes increased production of RBC. When you have increased production of RBCs, means now there is no blood oxygen, now there is sufficient oxygen. So this sufficient number of oxygen and sufficient number of RBCs, they inhibits the further production of erythropoietin. So the agents which are responsible for causing erythropoiesis are called erythropoiesis stimulating agents, and these are ESAs, TPO mimetics, and GCSF, granulocyte colony stimulating factors. So these are the medications which stimulate the bone marrow to make more blood cells. In conditions where there is anemia due to end-stage kidney disease, when the kidney is not able to produce its original erythropoietin, then you go for ESAs. Or in the case of chemotherapy, in case of any major surgery, or in HIV or AIDS, in immunocompromised conditions when there is no formation of red blood cells. So another way you think to produce RBCs is to give erythropoietin stimulating agents. They are usually given, and they are all given by injection. There are certain types, certain names: erythropoietin, apoietin alpha, apoietin beta, darbepoetin, and methoxypolyethylene glycol apoietin beta. Toxicity, if happens, it happens only in the concerns of serious hypertension or thrombotic complications. So what is recommended, that if you are giving erythropoietin stimulating factors, then keep checking the hemoglobin level. If the hemoglobin level is 13, you stop giving the erythropoietin stimulating agents. So whenever you are giving it, the hemoglobin level should not exceed 12 in patients with chronic kidney diseases receiving these. The other kind of factors are myeloid growth factors. Myeloid stand for bone marrow. These are two types: GCSF, granulocyte colony stimulating factor, and GMCSF, granulocyte and macrophage colony stimulating factor. These are what? These are glycoprotein hormones, and they also regulate the proliferation differentiation of different hematopoietic progenitor cells in the bone marrow. Progenitor are the stem cells. Okay, if you don't understand what is progenitor are the stem cells which are going to further produce different RBC, WBC platelets. Now the first growth factor which was discovered were these colony stimulating factors. And why they are called colony stimulating? Because they can stimulate the growth of colonies of, means many million amount of various bone marrow cells. These are different names, as you can see: GMCSF, GCSF, MCSF. This is only for the production of monocyte. Erythropoietin, it is for erythrocytes or RBCs. Then you can see interleukin 1, 3, 6. These are for myeloid lineage, different cells. Then you can see in the end thrombopoietin, and it is only for the production of platelets. There is a newer drug, romiplostim. It is a novel biological agent that activates the thrombopoietin receptor. And this thrombopoietin receptor, what does it do? It causes increased production in platelet in conditions of thrombocytopenia. So the pharmacodynamics of these growth factors are, they interact with specific receptors, and these receptors are found on myeloid progenitor cells. They stimulate all the cells, neutrophils, granulocytes, erythroid, megakaryocyte. They stimulate the function of all these cells, and they stimulate the function of mature neutrophils as well. And if you are giving a combination of GM-CSF plus interleukin 2, it will stimulate T cell proliferation, lymphocytes, and appears to be a locally active factor at the site of inflammation. So in short, the pharmacodynamics of GCSF and GM-CSF, they are causing the stimulated proliferation and differentiation of granulocyte, erythroid, megakaryocytes, and neutrophils. Here in this figure you can see GCSF is responsible for neutrophil production, GM-CSF is responsible for both of them, neutrophil and macrophages. M-CSF is responsible for monocytes. Interleukin 7 is responsible for T lymphocytes, and EPO, erythropoietin, is responsible for the gross production of all these cells. This is also a figure. This one, just to explain you more how they all work. Different stimulating factors are responsible for the differentiation and proliferation of different lineage, progenitor lineage. So when you are talking about the pharmacology of GCSF growth factor, they accelerate the rate of neutrophil recovery. In cancer, chemotherapy induced neutropenia means if you have a patient with cancer and you are facing neutropenia because of the cytotoxic drugs, then along with the chemotherapy, you start giving GCSF to enhance the production of neutrophils. Similarly, GM-CSF also reduces the duration of neutropenia after chemotherapy. But GM-CSF does not reduce the incidence of febrile neutropenia because it itself causes fever. What does it mean? That whenever the patients feel fever in neutropenia caused by chemotherapy drugs, GM-CSF is less causing the reduction of incidence as compared to GCSF, means GCSF is better. Both of these have been approval for the treatment in acute myeloid leukemia as well. Another term it's written in your book is autologous stem cell transplantations for the patients undergoing high-dose chemotherapy. In this process of transplantation, these colony factors are also being given, and what does it do? It reduces the time to engraftment and to recovery from neutropenia. Patients with multiple myeloma or non-Hodgkin lymphoma, and when they do not respond or respond less with the GCSF alone, then you can give another novel new hematopoietic stem cell mobilizer, plerixafor. Okay, so whenever you have a condition of multiple myeloma or non-Hodgkin lymphoma, and in this condition if the GCSF is not sufficient alone, so there is a new stem cell mobilizer drug, plerixafor. Okay, is there any toxicity? Yes, there is some toxicity, and it causes bone pain. GM-CSF sometimes cause fever, malaise, arthralgias, myalgias, and a capillary leak syndrome, which is characterized by peripheral edema or effusions in pleura or pericardium. Some allergic reactions are always expected with any kind of drug. The last growth factor are megakaryocyte growth factors. These are 3: thrombopoietin, interleukin 11, and romiflostin. All of these 3 are responsible for the platelet production. So this interleukin 11 acts through a specific cell surface cytokine receptor, and then it stimulates growth of multiple lymphoid and myeloid cells. It acts with other growth factors also to cause primitive megakaryocyte progenitors to mature, to proliferate, to differentiate, and ultimately to increase the number of peripheral platelets and neutrophils. The newer drug, the name is romiflostin. Romiflostin causes a dose-dependent increase in platelet count that begins on the 5th day after subcutaneous administration, and it reaches its peak concentration at 15 days. Now, what are the uses of interleukin 11? It is used for the secondary prevention of thrombocytopenia if the patients are receiving cytotoxic drugs which are causing the deficiency of platelets in non-myeloid cancers. Again, if you are giving interleukin 11, it have the chances of reduction in the platelet transfusions. In which cases platelet transfusions occur? In the cases of thrombocytopenia. And thrombocytopenia caused by which drugs? Cytotoxic drugs. So what is the use of interleukin 11? To produce platelets to treat thrombocytopenia, especially thrombocytopenia caused by cytotoxic drugs. Is there any toxicity of interleukin 11? Somewhat, yes. Fatigue, headache, dizziness, and some serious effects like dyspnea or arrhythmias. Hypokalemia also sometimes occur. Always pay attention to the serious adverse effects, because if you are not giving interleukin 11, nobody is gonna die. But if you are giving excessive interleukin without getting checked, without looking at the adverse effects, you can have a life-threatening experience of the patient. The newer drug romiflostim appears to be well tolerated as compared to interleukin 11, except it causes only a mild headache on first day of administration.